Okay, we're gonna have a couple of videos, kind of quicker, shorter ones right here. Just going through a lot of the little extra tidbits. So spinal curvatures, we separate the different types of curvatures into primary and secondary curvatures. The primary ones, these are ones that we are born with, that we naturally have. These are our kyphotic curves. The secondary curvatures are ones that develop with growth. These are our lordotic curves. These also tend to be the ones that more often we have pathological issues with, because they can also, as we age, as we get older, they can slightly overdevelop, if you will. So cervical and lumbar, they are our lordotic or lordosis curve. The cervical curve develops from as a baby lifting your head. This is why babies do tummy time. The thoracic is kyphosis primary, so we're born with that specific curve. Lumbar lordosis, this is developed from the psoas muscle activation from the action of crawling. That's why it's important that we want children to crawl before they walk. They have a good amount of time crawling, so that way they can develop their proper curvature of their spine. And then finally, the sacral curve is a primary curve, and that is again a kyphosis curve. So we can see we switch between lordosis, kyphosis. Sometimes, very rarely, they'll talk about it in curve of this in terms of of convex versus concave. Which part is concave? Which part is convex? So if you look at the curve, identify. So with the kyphosis, for example, the anterior portion is going to be our concave, posterior is convex, cervical and lumbar are going to be opposite that. Finally, we briefly mentioned a little bit about the facets. We're going to dive a little bit deeper into the facets. With this, we want to know two things. We want to know which direction the facets face, specifically the superior and the inferior facets as they go down the spine. And then we also want to know the facet plane angle in the degrees, as well as, then we'll talk about the spinal movements. So cervical spine is about 45 degrees. Thoracic spine, they're angled at a 60-degree angle. Then the lumbar spine, they are at a 90-degree angle for the majority of them. L5S1, that sort of transition, also has a little bit funky. It's actually at 120 degrees instead of 90. So that was a little bit different. So we want to make sure that we know these numbers as well as the plane. So cervical is typically in the oblique plane, somewhere between the transverse and the coronal planes. The coronal we usually consider is more in the frontal plane. And then the lumbar is in the sagittal plane primarily. The actual directions of the facets, this doesn't get asked super often, and it can be a little bit confusing just because of the way that they like to ask it. Specifically in part one, they don't always follow proper anatomy. The general rule that we will follow is that all of our superior facets are angled posterior and superior. That's kind of the general rule boards follow, even though it's not the most accurate. That's typically what they say. And then again, all of the inferior facets are anterior, inferior, and then either lateral or medial. Cervical, they'll typically say is lateral, whereas the thoracic, they'll say is medial. It's not entirely correct. However, it's the way that part one will typically kind of group those by. It is what it is. Part one, you just kind of have to go with the flow and learn a couple of these little details, even if they're not 100% perfect. That's the way that they'll like to ask them. The movements of the spine. So we have primary and we have secondary spinal movements. The primary movements, these are the intentional ones that are between the vertebrae. The secondary movements, these are our passive, also known as our coupled motions. So for example, in the cervical spine, whenever we rotate, we also do get a little bit of extension. The primary movement within the cervical spine is technically rotation. This isn't actually, these are the main primary and secondary movements. The cervical spine, because of how mobile our necks are, most movements are considered primary for the cervical spine. So if you're going to get asked about what's like the most correct for the primary movement of the cervical spine, it's rotation. So that's why I have it up there. If you read any other textbook, you'll see that the cervical movement is pretty much all of them as primary movements, with a good chunk of them also being secondary movements, depending on what the primary movement is. But these are the ones that we want to know for this exam. The thoracic primary movement, again, is going to be rotation as well. And then the secondary movement is going to be flexion. So with rotation, we also get flexion within the thoracic spine. And then the lumbar, mainly flexion is our main movement is flexion. And then again, we also get rotation with that. The coupled motions that you're going to get asked about the most, kind of those secondary movements, they'll ask a little bit more. This will pop up part 2, part 3, when you're talking about some of the spinal anatomy specific stuff. These will pop up in those exams a little more, but you can have a question on this here. So with lateral flexion, we get, in the cervical spine, we get ipsilateral rotation. So if we right lateral flex, the body rotates to the right as well. In the lumbar, if we laterally flex, so this will be go right lateral flexion, that causes left body rotation. Finally, the boundaries of the IVF, intervertebral foramen. Anteriorly, we have the vertebral bodies as well as the disc, uncinate processes, rib heads, that kind of stuff. Posterior, the articular facets, the Z joints, all that's good stuff. Superior are the pedicles, and then inferior is also the pedicle. Finally, some extras. If the L5 is fused, we'll continue this in a sec.